So excited to talk to you all about asthma today. We don't have any financial disclosures.
So our objectives overall today are to talk about how we implement asthma treatment guidelines in both the ER and the inpatient setting based on severity. We'll also talk about the pediatric asthma score that we utilize to guide our clinical management. We'll talk more about kind of what we use for criteria for PICU admission versus transfer, and then also talk about how we apply some of our newer preventative measures and some of the newer evidence in terms of asthma management in an outpatient setting. So kind of thinking through this, a lot of the topics that we focused on are things that have a big impact in terms of our pediatric population. And so therefore our ERs and our hospitals in terms of taking care of these kids. So about 1 in 11 children in the US are diagnosed with asthma. And that results in about 1 in 5 of those children having an asthma visit to the ER each year. And so it's also been a leading cause of hospitalization for children in the United States.
It was so, we had that break during COVID where it felt like we weren't seeing kids with asthma complaints. And it feels like really since then, with both our viruses and our kind of straightforward asthma, it's been kind of back full force since then.
Yeah, and I would say, I don't know what you all are seeing in your communities, but as Leah had mentioned, we had a case where we actually overlapped on taking care of that patient, but we've been seeing a ton of asthma this last month. So I don't know if anybody else wants to share, what you're seeing in your settings. If anybody wants to chime in, feel free to do that. While we're waiting for that, I'll go through our pediatric asthma score. So our pediatric asthma score has multiple components. This is fairly standardized and a lot of different institutions utilize it. So you can see that the main components are looking at the child's respiratory rate, whether or not they require oxygen, what they sound like when you examine them, and then also looking for their work of breathing. So do they have retractions, and then do they have dyspnea when they're communicating with us? In terms of our overall kind of categorizing these kids, we consider a 5 to 7 mild, 8 to 11 score moderate, and then a severe score 12 to 15. I would say the majority of the kids that I take care of typically present with a moderate or severe score.
And I think one thing that is important to talk about, because we run into this frequently, and especially with trainees, is that there are multiple pediatric asthma scores out there, and several of them are called pediatric asthma score. So if you look up PAS, you might find something different than this, which is fine. I think that many of them have been validated, but what's tricky is that the scale can be different. So ours runs, as you can see, between 5 and 15. There's some that kind of run all the way from 1 up. And so if you think you're using one scale and you get a number, you just want to make sure that the scale matches the one that you're using. So we'll talk about our pathway in a minute, but really the kind of mainstays of asthma treatment are albuterol and steroids. So we wanted to take a minute to talk about those specifically first. So albuterol, when you look it up, the weight-based dosing is 0.15 mg per kg, which I don't think I've ever used. We sort of lump it into groups. And so we treat our smaller children, so less than 20 kilos, with 2.5 milligram treatments or 6 puffs at a time. And then our kids over 20 kilos, we treat with 5 milligrams if we're giving it nebulized, or 12 puffs. And then for our kids who are moderate or severe, we usually treat them with back-to-back treatments, we call it. So those 3 treatments, officially it's every 20 minutes, but really, it's sort of whenever the first neb finishes, we tend to start the second one as long as they're still symptomatic for 3 of those over that first hour that they come in. For us, that's the easiest way to get albuterol in quickly. For some places, it's easier to give continuous, to give them, between 10 and 20 milligrams an hour over that first hour. So it's pretty equivalent if you look at the numbers, depending on what weight you're using and what dose, but it's kind of however you can get albuterol into the child quickly. And then there have been some good studies that show that inhalers, when used with a spacer, are pretty equivalent to nebulized treatments in terms of efficacy. But what's interesting is that sort of more recently on the scene are the vibrating mesh nebulizers. And there's some emerging evidence that they might be more effective at medication delivery. Basically, it's like a fine metal mesh that makes for smaller particles and so helps the medication to be delivered into the smaller airways. our respiratory therapists have been big proponents of it. They really feel like it makes a difference. I have to say, in terms of the evidence, I've not seen it kind of play out in studies yet, but sometimes there's, that lag while we're still studying things. And I actually found a randomized control trial of it, but it's literally like in that phase where it's been published, but I can't access results yet. The other data that I've seen has all been related to the manufacturers. And so that's one that I'll take with a grain of salt. I don't know if you all, if anyone's using vibrating mesh nebulizers, if anyone has sort of seen a difference.
Yeah, can you explain what that is? Because we haven't heard that.
So the brand name is Aerogen that we use. I think there are several of them, and it looks very much like a nebulizer. There's sort of a handheld component, but it's a little like metal mesh membrane that the medication, you still hook it up to oxygen. It requires less flow because of that vibration. That's what aerosolizes the medication. And so it still sort of mists out in front of the patient's face. It tends to be a little bit quieter because there's less flow, but it wouldn't look that different if you didn't know. And then it's set up very similar to the way a nebulizer is with putting the liquid in. And we actually use the same medication that we use for our standard nebulizers. Hopefully that helps. And then I was just adding on about ipratropium here because we tend to do that with our first 3 treatments in the emergency department for patients who come in moderate or severe. There's some old evidence that shows that ipratropium can help to decrease the risk of hospitalization. Not good data once the patients have been hospitalized, so we tend not to use it routinely past those first 3 treatments.
And then I was thinking through in terms of the albuterol delivery for an RER, most typically you all use nebulizers. And so I think really for us, when they transition to a inhaler is in the inpatient setting, we still sometimes use nebulizers. But on our adult side, they actually have pushed really hard to go to nebulizers, partly for like environmental impact and those things. On the ped side, we've persisted with having those more for family and patient education, and so that we can work with them while they're in the hospital on using this spacer and those things, an appropriate technique. But I was curious for the rest of you all, if any of you guys are utilizing kind of what you're utilizing. Are you using nubs? Are you using MDIs? And then also, are you guys doing back-to-back nubs or tend to trend towards continuous? And then I was just going to also echo in the comments, there had been a comment about seeing mycoplasma. We've definitely seen that. And I've seen kids who have underlying asthma that ends up being a trigger for. And then, yeah, we've been seeing also a lot of influenza A.
Yeah, we had similar experience at Barton. The P&T committee decided to get rid of inhalers completely. And so we had only the option of nebulizers in-house until we advocated that we actually wanted to get we actually didn't even have inhaled corticosteroids in inhaler form. So we got those back for education and teaching purposes primarily. So funny how the pendulum swings back and forth. They used to want inhalers. Anyway, doesn't matter. I also enjoyed the comment that it's old data about ipratropium because that's like from when I was a resident.
Me too. I shouldn't. I'm not aging anyone else.
That was cutting edge. Yeah. And so anyway, that is a similar experience. And then I would say my biggest challenge is actually getting the ER to do this. We have a whole asthma pathway, but they just don't do it. They give like one neb and then they call. So we never get continuous unless we come and assess and say, hey, please give more. Or they call us on the phone and we're like, no, give them more. So I would say we're more a back-to-back type of place, but we also just have some challenges in getting enough albuterol to try to get the kids home.
We can talk afterwards too about some of the challenges with rolling out the pathway and getting it done, particularly in the ED. I can definitely speak to some of that from the inside, and Heather can speak to it from what she sees from the external perspective too. Before that, I will also say that I think it's important for families to see that inhalers work. I think some families come in and think that albuterol only works when it's given by nebulizer, and then they're really advocating to get nebulizers at home, and it's hard to prove that point if we're only using nebulizers in the hospital. So for our mild kids, we actually will give 6 or 12 puffs via inhaler because we don't have the ipratropium and we don't think they need it if they're mild. And so it's for our moderate to severe kids that are getting it via neb. Oh, and one more thing about albuterol, and I think this also may go, Rhonda, to what you were talking about, is that it's a lot of albuterol when you look at it and when you look at compared to what adults are sometimes given. And so I think then, and compared to what families are giving at home. So I think that sort of overcoming that hurdle and recognizing that, yes, this is a lot of albuterol, but children tolerate it well and they often need it is sort of an important piece that I think once you get over that hurdle, then people are more willing to give more. And then the steroid piece, I think, has kind of over time equaled out between dexamethasone and prednisolone or prednisone for our oral medications. I put the dosing up there that we use here at UC Davis. There's definitely a range, both in terms of the per kilo dosing and in terms of the maximum that people use. And I haven't found great data on any of that. For our kids that tolerate oral in the ED, we most often do dexamethasone, mostly just for simplicity. And there is some data that shows maybe there's some decreased vomiting with dexamethasone. And if we can avoid that, we definitely want to. And then if we're giving IV medication, we will typically give IV methylprednisolone with the doses that are listed there.
Yeah, I would say on the inpatient setting, most often the kids that we get admitted to us have gotten dexamethasone either at UC Davis or at one of our community hospitals. And then I think for me, kind of inpatient, going one direction or the other depends on severity. So the sicker the kid, the more likely I would be to do prednisolone or prednisone. And then it's pretty rare that I have a patient on the floor, but I've had a few where I have used solumetrol as well. But again, just for most severe patients.
So this is a picture of kind of the first page of our asthma pathway. So this is the ED portion of our asthma pathway, and the QR code in the bottom will take you to the Pediatric Clinical Guidelines website from UC Davis that will have the entire asthma pathway, so you can take a look at that. We don't need to go through it kind of step by step. Basically, the idea is that we assess the kids' pediatric asthma score when they come in. We treat them based on mild, moderate, or severe, and then we are rescoring them every hour. The kids that are mild will get a period of observation or not, depending on how mild they are. If they become mild after being moderate or severe, they'll be observed for a little bit longer time. For the ones that come in moderate or severe, like we said, we do those 3 back-to-back treatments for both sets. And then for the severe kids, we have started with the rollout of this asthma pathway of giving placing an IV at presentation and giving them magnesium, methylprednisolone, and then a normal saline or LR bolus at that point, and then kind of reassessing them at that second hour. We struggled a lot with what to do with kids that were moderate in that second hour. There seemed to be, that was sort of where our biggest range in our sort of variation in our treatment was. And what we have settled on is if they're still moderate at the beginning of the second hour, we do an hour of continuous. And so they've gotten their 3 back-to-backs, they've gotten medications either orally or IV, and then they'll do another hour of continuous. And then we assess at that point if we can space them out off of their albuterol. So even if they're still moderate, if they're not worsening, we will try to space them out and see if we can make it to every 2 hours if possible. But again, sort of all the details for the asthma pathway are available, and you can get them through that QR code if that's helpful to you.
Yeah, the only other thing I'd add is that if for some reason it's helpful to walk through the pathway, as we kind of revamped our asthma pathway, struggled with making it easy to comprehend for our own institution, as well as kind of interpreting that. So if that would be helpful, we're happy to do that.
Yeah. It was really more challenging, I think, to sort of put on paper what it is that we do or what we should do. So if other people have asthma pathways that they would like to share, I'd love to see them also. Maybe we can put them on that, our ECHO content website there, so that we can kind of compare and just see if there's ways that people have of displaying sort of both what you do and also displaying how you do it, so that we can communicate best. I get lots of complaints from my ED colleagues about, like, I don't know what this means the beginning of the second hour. So we have definitely struggled with that. The adjuncts that I have listed here, I talked a little bit magnesium we have been using for all of our severe presentations now. There's data, again, it's not super strong and still being studied, that it may reduce admission rate in moderate and severe asthma. There's a range of dosing. We tend to be sort of in the middle at 50 milligrams per kilogram, and we max at 2 grams. And then we typically do give an IV fluid bolus when we dose magnesium. The epinephrine we use most often in kids who present very severe. If they don't have an IV yet and we want to get medication into them right away, we use the 0.01 mg per kg, which is the same as our anaphylaxis dosing, and give it IM. And so we can get that into them quickly while we're establishing IV access and getting them on albuterol and all those things. And then terbutaline we tend to use in our kids who are not responding well to their initial treatments. Either they're staying severe or worsening despite our other medical therapies. And the doses are listed there as well.
What are the monitoring requirements for things like magnesium?
So for our magnesium, most of these kids are on pulse ox monitoring just because of the respiratory complaints. And I would say that most of them are actually on cardiopulmonary monitoring. I think that just keeping an eye on blood pressure, we actually don't have a specific protocol for how often they're monitoring blood pressures in these patients. But it is something that we're sort of aware of as a potential side effect.
I mean, one of our questions is giving magnesium in the ER and then moving into the floor. How long should we, what kind of things should we monitor and watch for next time?
And we didn't have so right now we tend to give magnesium early in the course. So most of the kids are observed for 2 hours before they get to the floor. But I think more of that is based on our concerns about their respiratory status and less about the side effects of magnesium. Because we're just watching to make sure that their respiratory status will be stable for the wards. So hopefully that's helpful. But even when we gave it late, again, it was mainly sort of watching respiratory was the reason that we would have concern about moving them up to the floor instead of vital sign concerns.
I think maybe said another way, I was wondering what's the frequency with which you see a pediatric patient have hypotension?
Yeah, so it's in terms of anecdotally, it is rare. And then in terms of the data, it's rare as well. There's not great studies about it. I have a colleague in Utah who's actually studying IV magnesium. And so he looked at it a lot because he's trying to get a study off the ground and everyone's worried about hypotension with magnesium. But it turns out that overall it's very rare. I can look up the numbers and get them back to the group. I didn't have them on the tip of my tongue for this. And then Heliox is the last one that I have listed there. It can be a nice option, although I feel like when we talk about our upper airway kids, we'll have more to say about it there. Because you're limited in how much oxygen you can supply. If we have really severe kids who are needing adjuncts, they often will need more than 30% FiO2, which is the limit of what we can give when we give Heliox. So I've used it a few times in our severe asthmatics, but not been able to use it regularly. And then one thing that's not on our asthma pathway is chest x-ray, because we do try to avoid it in our patients with routine asthma exacerbations. It's going to sound a little bit like a broken record because we talked about this in bronchiolitis too. But there is just not good, there is good data that it does not change management in the vast majority of patients. So we will get it in certain circumstances. And actually we'll talk about it in our case. That was a patient that we did get an x-ray in, but there's usually an underlying reason for it. High fever, persistently asymmetric exam, severe presentation, things like that, but not for our routine kids. And then thinking about kids who will need to be admitted, or depending on what level of care you're able to give at your hospital, whether they'll need to be transferred out. So for our kids who are still symptomatic after that initial hour of therapy, so the 3 nebulized treatments and steroids. So if they're still having symptoms, they're still scoring in that, sort of moderate to severe range. And at that point, we pretty much assume that they will need to stay. And it's just a matter of what level of care. Or if we're able to, if they improve after those 3 treatments and we're able to observe them if their symptoms are recurring within 2 hours. So we usually watch them for at least 2 hours after we stop those treatments. And if their symptoms recur with wheezing, work of breathing, then we will bring them into the hospital and put them on the pathway. And then likewise, if they are needing albuterol, continuous albuterol for more than an hour, again, we assume that that's severity enough that they will need to stay. And then in terms of who needs the PICU, it's interesting. I feel like that sort of became easier once we implemented our pathway, that pretty much any child who is still severe after their initial therapy and their first hour of continuous is going to the PICU. Almost everyone else, if we can get them to moderate and keep them in moderate, we're able to, at least now with our current pathway, manage them on the ward. So as you're thinking about sort of who you can keep, I think that's at least how we think about it here at UC Davis.
Yeah, that's one of the challenges out here in Ukiah because we're an hour away from anybody. And so if someone's on the fence, do I keep them and think we can probably do it, or should I just send them because they might get worse?
I think one of the things that was helpful to us when we were trying to put things together, because at the point we kind of revamped our pathway, we were not doing any continuous on the floor, and we were having the ER observe the patients for a lot longer than we currently are. And one of the things that was most reassuring in our data was that it was pretty rare for a patient to escalate once they had started progressing down the pathway and, like Leah was describing, had gotten to a place where they were moderate in terms of their respiratory symptoms. I just wanted to highlight some of the things we think about. I think in the ER setting, there is probably less focus on this, appropriately so, but I think it is helpful because I think in terms of thinking, whether you directly manage it or whether you make sure they follow up with their PCP, for a lot of these kids who present to the ER with asthma, they really would benefit from further management outpatient in terms of inhaled corticosteroids and those things. And so I think the other complication is, as we all know with any pediatric patient, is it's not easy always to know what symptoms the child's having. If you have a toddler who can't either verbalize it or accurately verbalize it, and parents who are kind of trying to guess at what the child's feeling, I think there's a lot of kids who may have mild chronic symptoms that it's just hard for us to tease out and to recognize. But some of the things that help is thinking about their frequency of symptoms, how often they're using albuterol, whether or not they have any symptoms with activity or at night, which honestly for me is pretty rare, even for our more severe asthmatics, that I get a positive history. Atopic symptoms is at least a good clue that they're at risk in terms of, like, do they have eczema? Do they have seasonal allergies? And then their past medical history. I find that often is really interesting because a fair number of these kids will have had some either interaction with the ER previously or an admission where they received albuterol. And at that point, they may not have been called asthma, but that then kind of raises my threshold of the likelihood of them having asthma. Other things, hospitalizations, intubations, also kind of thinking through, does this patient have any risk factors for chronic lung disease? Are they premature? Family history is always, like, if I had to limit it to just a few questions, that would be one in terms of, are there any direct family members who have asthma? Thinking about tobacco smoke exposure in this population, and then medications. Medications is always an interesting one too. Like, if I just ask what medications they're on or have been on, I don't often get great information, but I try to be more specific in these patients in terms of, have they ever had breathing treatments in the past? Have they ever used an inhaler? And if so, what kind?
Heather, I don't know if you run into this. We often hear about inhalers in terms of their colors. Families are telling us they'll use the red ones for rescue and the blue one is an everyday. And I'm always hoping that either I have some medication history or they bring them with them, because none of that means anything to me. We were going to talk just a little bit about some of the kind of respiratory support that we think about in our more severe kiddos, and high flow nasal cannula is listed here, but actually there's very limited data for how we can use it in asthma. I think that it's become so successful for us in bronchiolitis that we sort of want to be able to use it in asthma, but there really isn't data that it's particularly helpful. And specifically, there's some concern that if you're trying to give albuterol, especially continuous albuterol while you're giving high flow, that it doesn't get delivered well. And so we typically don't use it in kids who are coming in with straightforward asthma exacerbations. There are some cases where they'll overlap with other diagnoses and we end up using it. I'd say the younger kids where we're not sure whether it's bronchiolitis or asthma will sometimes go back and forth between our pathways, which can be frustrating for those of us that like things to fit neatly into one box. And then for kids with an underlying pneumonia, we think about it. But again, if it's just strict asthma, we tend not to go to this. And so for our kids who are still having significant, so thinking about severe respiratory effort despite our medications, we will talk about doing non-invasive positive pressure with CPAP or BiPAP. And often we'll start with CPAP. We want our kids to be sort of alert and able to manage their secretions if we're going to put them on BiPAP or CPAP, especially because we tend to use the full face more often because they tolerate that better. And then we will titrate it once we get them on. We will sort of increase pressures and see if we're able to get better albuterol delivery, better aeration, and ultimately sort of hope to improve their mental status and their work of breathing. And then for our most severe kids, where despite sort of all of our maximal therapy and our non-invasive support, they're continuing to worsen, we will intubate them if we need to. It really is like our last ditch effort, and we will do everything we can not to intubate them, mostly because it doesn't solve the problem when we intubate them, right? We can take over some of their work of breathing, but these kids are usually compensating better than we'll be able to for them, at least for quite a while. And so we will usually use mental status and then their sort of just their overall work of breathing as our two markers. We get blood gases on these kids and try not to overreact when we see if they are dramatic. They can be useful for trending to see if gases are getting better or worse, but try not to act on just an isolated value, particularly an isolated hypercarbia in these kids, again, especially early in treatment where we still have hope of them responding to medications. If we do need to intubate, we most often use ketamine for our sedation because it does have some bronchodilatory effects and can be helpful for that. And then again, it's often very difficult to ventilate these kids once they're intubated. There's not one specific mode of ventilation that's been shown to be better than others, but sort of the overall principles are trying to limit barotrauma and limit hyperinflation. So using a slow respiratory rate and a long expiratory time. So your I to E ratio, you want to be really on that expiratory phase. And then allowing for some hypercapnia. So these are not kids we're trying to get their gases perfect. We are willing to let them be hypercapnic if we can kind of get other things in line. And then for these kids, at least in the emergency department, if they get intubated, we're pretty heavily sedating them and usually muscle relaxing them because any asynchrony with the vent can cause a lot of difficulty in ventilating them as well.
I wanted to just briefly touch on asthma classification. Our primary purpose, I think, is really to determine outpatient treatment. But I do think it's helpful also for me in terms of thinking of the severity of that kid's asthma and kind of what I might expect for their clinical course. So if you look where the yellow box is it intermittent? Is it the kid who always wheezes every time they get a cold? Or is it more persistent? So mild, moderate, or severe? And so do they have symptoms when they're not ill? If I had to completely simplify it, would be kind of my questions. And so that just helps us in terms of figuring out what interventions we can take in order to try to keep these kids out of the ER and out of the hospital. This slide also dovetails to that. So on the left-hand side, you can see escalations of treatment, and I'm not going to walk through all of that, but just to think about that we often take a stepwise approach in terms of the interventions that we take in terms of chronic medications and managing these kids. But I think two of the most interesting things about our pediatric population is thinking about mild asthma. There's good studies that support the use of intermittent inhaled corticosteroids plus short-acting beta agonists. For this, I think it's a really positive change. Like in the past, whenever I'd get told a history where the family was only using it when the kid was sick, I knew they weren't being adherent with the treatment. Whereas now we're using this a lot more frequently. I think obviously we can imagine for all of us that kind of decreases the burden on the families of taking a medication every day that they may not, number one, remember, but number two, necessarily be benefiting from as much for this mild asthma population. And so just to be aware that that's a strategy people are using more and more with this patient population. And then the second one in moderate to severe asthma is using what's called SMART therapy. So single maintenance and reliever therapy. I think the beauty of this is in that first word, single. I don't know if you guys have had this experience, but it is really confusing for families and even sometimes for us as medical providers to keep track of which med is which. And so this combines both an inhaled corticosteroid and a long-acting beta agonist. Technically, it's approved for kids greater than 5 years. I have had a few kids with really severe asthma, a little bit younger than that, that Pulm has used it on, but usually that's at that point they're involved in that decision. But a really good strategy, these patients can take it anywhere from once a day to twice a day to 4 times a day if they're actually having an exacerbation. So you can also use it in that setting, but it just really simplifies things for families, in my opinion. So we wanted to touch on kind of what are we using for our guidelines in terms of discharge from the hospital. So for our patients, they have to be on 6 puffs every 4 hours, and that's typically what we'll send them out on to continue that while they're on systemic steroids. Their O2 sat has to be greater than or equal to 90% on room air for greater than or equal to 4 hours. They need to be drinking well, and then we do asthma education with them as well. In terms of the things that we're thinking about in terms of what to send them out the door with, we send them out with albuterol, a spacer, and if they're young enough, a spacer and a mask. Controller medication if indicated. Again, I think for this population, if they're leaving from the ER, it's totally reasonable to have them follow up with their PCP during the time that they're on systemic steroids and work further on that. And then an asthma action plan, primary care follow-up, and then I think, and this is one question, I think some of you guys are doing some outpatient, but if there's anybody here who is of which, or just has your finger on the pulse of that, of which patients we're referring to pulmonology. For us, we tend to refer any patient who was in the ICU or had a more severe course. But I find, interestingly, like a lot of families actually, even for mild asthma, inquire about pulmonology follow-up. And so we certainly will work with families to achieve that as well. But oftentimes we'll also just send them back to their PCP and let the PCP kind of make that decision as well. So kind of summarizing everything that we've talked about, asthma is a common reason for ER and inpatient care. Guidelines and scoring standardize our treatment, and these new modalities of using intermittent inhaled corticosteroids for mild asthma and smart therapy for moderate or severe asthma are some of the updates. When I went to update some of the graphs, I was like thinking, oh, there's probably something that looks better or is updated. But really, since those 2007 guidelines came out, they've continued to update it, but kind of the framework has all stayed the same.